The talk is really focusing on use of circulating tumor DNA as a minimal residual disease biomarker. So we first of all start off by discussing why minimal residual disease is important in non-small cell lung cancer. So we highlight the way that we currently give adjuvant treatment in lung cancer, and discuss how if we had a biomarker that could identify patients with residual disease after surgery, that could improve the accuracy by which we give adjuvant treatment. And then we move on to discuss how minimal residual disease as biomarker could really alter the way we conduct adjuvant drug development. And there's a real need there because we know that our therapies can potentially cure patients in the adjuvant setting, but conducting these studies by conventional means is challenging because you need to recruit very many hundreds or even thousands of patients to the studies. But if we had minimal residual disease biomarkers, we could conduct much more focused studies where we just escalate patients to treatment when they're destined to relapse from their cancer. So I think there's huge potential there to incorporate minimal residual disease in that setting. And then there is one study that's come out this year from Tom Powles at Barts, who worked with the Genentech team, who utilised retrospective circulating tumor DNA analyses in the IMvigor 10 study. And this study really acts as a proof of principle to show that you can use minimal residual disease to identify a patient population who benefits from escalation of adjuvant treatment. So we highlight that groundbreaking work as well. And then really it's the talk moves on to highlight the technical challenges that are involved in detecting these very low quantities of circulating tumor DNA after treatment, and how in the lung TRACERx study, which is a study that I work on, we've used a certain methodological approach to overcome some of those challenges. And that approach we've been developing over the last 5 years is a tumor-informed personalized approach, which means we sequence patients' primary tumors, we look for mutations in those tumors to create an enrichment panel that's different for each patient. And then we take that enrichment panel and apply it to cell-free DNA to detect these low quantities of ctDNA. So we discuss that. We share some data from TRACERx that really shows as a proof of principle that you can detect minimal residual disease after surgery in non-small cell lung cancer, and highlight how minimal residual disease detection can complement imaging surveillance after surgery. And then to finish up the talk, I highlight the ongoing adjuvant studies utilising minimal residual disease as a biomarker, which really show that over the next few years we can expect some data to emerge that can inform our practice as physicians. So that's really a summary of the talk.